Okay, I think we're ready to get started. Thank you so much for joining us for the Women in Medicine webinar titled COVID-19 and Equity, Let's Not Lose Ground. This conference is being presented by the Women in Medicine Summit. We are thrilled to be able to bring this conference to you virtually in this time of COVID-19. I know that we owe everyone fighting on the front lines a big thank you. We have over 250 participants here today. And before we get started, I want to cover just a few housekeeping topics. So first, this conference is being recorded. We will be able to share a link with you after the event is complete, and we welcome you to revisit this content yourself in the future. We also invite your comments and questions. Please look at the Q&A box on your screen, and if you think of a question for the speakers at any point, just type it in there and we will pose it to our speakers during the question and answer session. If you want to chat amongst the audience, please use the chat box feature. And please remember to use the Q&A box for questions directed towards the speakers. So at this time, I'm going to hand it over to our moderator, Dr. Thomas Varghese, to lead the sessions. So Dr. Varghese is a leader in healthcare in many, many ways, and he is also the assistant chair for our He for She track this year at the Women in Medicine Summit. He is a nationally and internationally renowned surgeon, and we are honored to have him today moderating this summit virtual webinar. So with that, I hand it over to Dr. Varghese.
Thanks so much, Dr. Jane, and it's an incredible honor and privilege to be here with all of you in virtual space. But I get the distinguished honor of introducing our esteemed faculty presenters tonight. And so as we go to the next slide, our first speaker is Dr. Vineet Arora, who is the Herbert T. Abelson Professor of Medicine, Assistant Dean for Scholarship and Discovery, and Associate Chief Medical Officer for the Clinical Learning Environment at the University of Chicago. She's an accomplished scholar who is also an elected member of the National Academy of Medicine and the American Society of Clinical Investigation. In addition to using system science and learning theory to improve care and teaching hospitals, she has made significant investments training the future generation of physician scientists. She is a principal investigator of a new NIH diversity program consortium grant to improve mentoring for aspiring women and minority physician scientists. And she's also a founding member of Time's Up Healthcare and was featured on the cover of the New York Times for a JAM editorial calling for an end to gender pay gap in medicine. She currently serves on the leadership group of the National Academy's Collaborative to End Sexual Harassment in Higher Education and is a steering member, committee member and speaker for the 2020 Women of Medicine Summit. We're honored really tonight to have her present on the impact of the current pandemic on gender equity efforts. And as we transition to Dr. Arora's slides, you'll be seeing a small poll going up. But Dr. Arora, thank you for taking the opportunity to join us here tonight.
Thank you so much for having me, and I hope everybody can see my slides. I wanted to start out by saying it's a pleasure to be able to join you in this virtual space, and I'm broadcasting, of course, from my basement and sitting here actually propping my computer up on my kid's toy chest. And so with that, it's not surprising that one of the topics that I'm passionate about, gender equity, intersects with what we are dealing with the COVID crisis. And so one of the things I'm really concerned about is let's not lose the ground and the momentum that we've gained. And so I welcome you to follow me on Twitter at Future Docs as well, so we can continue the discussion there. And let me just advance the slides. So did you want to discuss the poll first, Tom, or do you want me to just keep going?
No, or we could just make a passing note and we could probably come back to it during the panel discussion, but sadly, it looks like the vast majority have felt that their institution is not implementing equity efforts during the pandemic, which probably shouldn't be surprising to all of us, hence the topic of tonight's conference. But it is something notable. It's a 61% feel that their institution hasn't done enough to support.
Wow, that's stunning. And hopefully that's something that we will be able to really address as we think about this together. So I look forward to talking more about that with you. So as we start off, I'm sure many of you, women and men alike, are all at home or possibly in your office, but the shelter in place coupled with closing of schools has led to a major household upheaval, no matter who you are and what gender identity that you have. However, one of the things to keep in mind is that we know from really good research that women, especially mothers, especially bear the brunt of childcare, caregiving for elders, and household responsibilities. And this is going to be likely greater with the COVID era, with homeschooling and teleschooling, as well as the potential for sick family members. It's possible that you have a grandparent in a nursing home that needed to go to the hospital, for example. And so women, especially moms and caregivers, are likely paying a bigger penalty for COVID in the workplace. I want to give a special shout out to the single moms out there who are doing it, whether single by choice or whether single by circumstance or whether single because of health issues or because they're married to an essential worker. It is going to be an issue. And the New York Times raised this issue when mom Zoom meeting is the one that has to wait. And so what we've really done is COVID has unmasked so much health inequity that I'm excited to hear my co-panelist Niva talk about as well. And that's also the same true for gender equity. Now, what about working women in COVID? Not just women in medicine, but all women. And so, women make up the majority of the essential workers in healthcare. 76% of essential workers in healthcare are women, predominantly nurses, but also in government and community-based services. And so, so it's not just the women on the front lines who are physicians. This is a lot of women out there that are actually leaving their home and continuing to provide care. They already face a huge gender pay gap. We don't need to go into the data on that. And then with the economic downturn, this may make women especially vulnerable to job loss or furlough. Also, again, particularly concerning for moms who are the sole breadwinner in their home. What about healthcare workers in COVID? This is a stunning report from the CDC. Data as the end of May. This is just fresh off the press last 2 days. 62,000 cases in healthcare workers, 291 deaths. 75% of the cases of COVID in healthcare workers are in women. And that's interesting because not only are women more likely to be essential healthcare workers, the rate of PPE failures is also higher in women, postulated to be due to mask fit as well as smaller faces. One caveat on this data is that the CDC footnote says healthcare personnel status was only available in 21% of people, and death status was only available in 56% of healthcare workers. So for any of you researchers out there, I know that this would not be data that you would stand your an assessment on. And so it's likely a huge gross underestimate, and we're going to need to see what comes out. But clearly, it's sort of showing the gap where women are more affected. So I want to spend the rest of my time talking about solutions because, like we all know, this is a big hit. How can we fix this? And so, fortunately, interestingly, as Tom mentioned, I'm involved with Time's Up Healthcare. The Time's Up Now group released a really comprehensive guide to equity inclusion during the crisis that I encourage all of you to go download. It is free. It's comprehensive. And in addition to issues around equity inclusion that are important for everybody, they really talk about a key thing about the COVID era is don't forget about paid sick days and paid family medical leave. And so I just wanted to highlight to institutional leaders as well as those working in institutions alike, don't forget to advocate for these types of things because this is even more important in the COVID era. So when we think about women in medicine, what are some of the support structures we can use from home? And so one possibility is that can institutions and employers support work from home for those that bear the brunt of childcare? And one could be a childcare or childcare subsidy. Now there are pros and cons to this, given that even my own institution has set up childcare subsidies for certain daycares, but you can imagine we're in the middle of a pandemic, and as a physician, you might be very concerned about having the same reason that we're trying to socially distance is, and then sending your kid off to be in a social space with other kids might be difficult to do. Maybe you have no choice, but it's something that's a personal risk tolerance. So there is a pro and con to there, but generally we should be erring on the side of at least offering that. So we should encourage institutions to offer that. I did want to offer a do-it-yourself solution from my own backyard, which is the UChicago Primary Care Group. And this is a tweet that one of our physicians posted that several of our physicians actually, who are all frontline clinical care providers, when our school closed, they're like, what are we going to do? And so as you can see here, they created their own homeschool where with parents as well as a hired teacher, they were able to rotate their kids at somebody's house and actually keep that homeschool going. Now it does require merging your families. And so if somebody in the unit goes down, they all go down, but at the same time, they're all in part of a practice together. So one of the interesting things is perhaps this requires merging your home and work a little more closely to get it going. The other thing I will say is that it's important to normalize that childcare is occurring. And talking with a lot of my colleagues, there's this assumption that you're at home, you're free all the time, you're free at 6, you're free on the weekend. And so we need to think about family-friendly Zoom times and still maintaining some work-life balance. On the topic of Zoom, I did want to discuss what Zoom is like in terms of the equity world. And so since all of us are seeing each other virtually, one could imagine that perhaps the equity solutions are a little bit easier. We're all in equal size box on a screen, if you will. However, I would posit that all voices are not heard the same, and that could be the same voices are heard. And the question really is, are diverse voices heard? Are women heard? Persons of color, the intersectionality, interprofessional. And so this is my own personal observation. I welcome yours as well, that women are more likely to be on video and audio mute because they have stuff going on in the background, and they use the chat to be respectful given the family chaos, or they're calling in on mobile with no chat. And that's concerning because sometimes they risk not being heard. And so you really need to think about, well, as a moderator, how do I make sure every voice is heard? And just wanted to give a shout out to my all-women team at the Pritzker Scholarship and Discovery program that actually executed a virtual senior scientific poster session for over 50 students. And so you can imagine this is us excited that we pulled it off after we finished doing the awards. And all of us have kids in the background, and so just something to keep in mind that it is normalized. So one of the things we did at our institution was we actually developed sort of a Zoom best practices. And our Zoom best practices is really about optimizing teaming on Zoom. But when I thought about the equity lens, I thought, you know what? We should be thinking about this in terms of equity as well. And so potential Zoom solutions are, you announce that you are going to use the chat to avoid interruptions. Use the back channel to the moderator to let them know, please announce my comments so people can hear it. And as a moderator, read those comments so it's heard, so that even if you're not looking at the chat, you're trying to get everybody's voice heard. And this would avert the risk of what Esther Chu and others have called, as well as of common vernacular, mansplaining or bro-appropriate, where you might actually put something in the chat and then 2 seconds later somebody has claimed it on the Zoom and you're like, hey, I was in the chat first. And so so that's just something to think about in terms of moderators in this era. I do want to give a shout out to my friend and co-founder of an advocacy organization, along with Shika Jain, who's one of our organizers today, of Impact, Eve Bloomgarden, who's an endocrinologist at Northwestern, who's been doing telehealth visits from her house. And she emailed me and said, I've been thinking about telehealth equity and, what do my patients see from my home? Because my colleagues who are men have been going in and this is what they see. And so this is the ortho blog, 5 steps to prepare for a telehealth service. And you see this professional looking physician. And then Eve sent me and gave me permission to use, this is what her patients might see if she actually didn't use a Zoom background. But even if you did, as you know, like your kids can invade that Zoom background pretty easy. And so one of the questions is, how do we normalize what patients see? And some of the women I've talked to have highlighted how their patients have enjoyed some of that, or allowing people to understand and preparing patients that, you're going to be chatting with the doctor in the doctor's home. And so keep that in mind. What about clinical equity with COVID? I did actually use Facebook to call some responses around this, especially in the academic research moms group, as well as the physician women in leadership group. And so clinical equity came up a lot for women. Women are likely to be heavy clinical on the front line of COVID, maybe because they're not in leadership positions or power. I would say also, they're not considered high risk. That early data out of China in excess male mortality really actually gave some institutions some early thinking that, you know, are you high risk or not? And men who are older men could declare themselves high risk. And so we found that a lot of our COVID frontline units are being staffed by women. And so that puts them at risk. And it takes them out of what they're, in academia at least, it takes them out of what they might be doing otherwise, which is their teaching or their research, et cetera. And that might have implications for long term. And so also, you know, because they're lower down on the totem pole, more recently to be lower recent hired, especially diverse trainees, there's a concern for furlough or being expendable. And so this is one of my collaborators, Dr. Leora Horowitz at NYU, who runs a Center for Healthcare Delivery Sciences and Innovation and is like a very senior researcher who's staffing a COVID unit early on in charge of a dedicated COVID unit. And you can imagine that this is women, a lot of women are like this. I've seen a lot of pictures of women out there on the front lines. And so thinking about women in research, I had seen some early data out of non-medical journals, but fortunately, Dr. Reshma Jagsi, who's just a pioneer in this space, has rectified that and now given us the first early data for women in medicine. And this is from a preprint of a collaboration that she did with Dr. Russell Lewis, as well as a group, Jens Peter Anderson, where they looked at thousands of studies in top journals in medical journals, and they found that 23% lower first author for women, 16% lower senior author, 16% lower for any author on COVID-19 papers in top medical journals. And they compared this, the control group was 2019 papers, all 2019 papers published in the same journals compared to COVID topics. And so as you know, COVID papers have been accelerated to get to press quickly. And so this sort of highlights in the effort to get to press quickly, who's there working and becoming a thought leader in COVID and putting the data out there. And so we can see that there is a gap that's forming even compared to what women were doing in 2019. The COVID 2020 era does not look as good. What about clinical trials? I will say this is concerning because the gap may widen. We're seeing an acute gap, but the thing about publications is some publications may have been like already sitting there and just waiting to get wrapped up. So perhaps somebody had a hand hygiene project and they're like, hey, this is going to be really hot now. Let's get this out of the door. Whereas what about people starting new projects and submitting grants? And so this is from clinicaltrials.gov, and you can see women are actually registering fewer research projects. These are prospective, and so this is years to come. We're going to see a potential gap. Are they being excluded because of from COVID research because of the assumption of clinical or home duties, or do they just not have time to participate? We don't know, but this is important because the impact on productivity of women may be even greater as time passes. So what can we do? Well, one possibility that we've talked about in my own team is working in teams of women. And so this allows for somebody to be batter up. So when, one of my colleagues, Shannon Martin, down at the lower end of the screen is like zooming in from her office because she's general medicine physician on call, the others of us can be like, and this was more of this was a women in medicine re-entry brunch for me from maternity leave. And so others of us can be with our children, others of us can be, doing the work. And so can we work in teams such that we normalize the home environment and we are able to produce? This will be actually a great tool for maximizing productivity for working parents, especially things like Google Docs where all of you can work together. That's been a tool that the Impact Group has used a lot, as well as sharing the load. And so you can actually start a new project, but all take a little bit of a piece of one. So this is actually in an effort to fight the infodemic with COVID, which is the misinformation. One of my PhD friends from policy school, I have a master's in public policy, and this is a friend of mine who has a PhD, who's a faculty at Dartmouth, and her colleagues started Dear Pandemic, which are self-proclaimed nerdy girl PhD epidemiologists. So she says to me, we're not doctors, but we claim to be fighting the infodemic. And so they literally started Dear Pandemic, over 10,000 hits, and they have huge social media reach. I recommend that you follow them. They split social media posts. Each of them take a day, take one question, and post a thoughtful answer. And through focus, they've cultivated that big following. And this is actually now becoming a scholarly pursuit. They're applying for a grant right now. Now, one thing about teams and team science is that it would require our promotion and tenure committees to really honor that. And so I can talk about that more in the chat, but I do think that's where we're going, which is we need to be much more upfront about team science. The next thing to think about is, maybe you can't really do the work at home. And so we have to change the work expected at home. And so I loved this paper, tongue-in-cheek, Annals of Florida Academic Moms, the unsuccessful application of behavioral analysis to balancing work, homeschooling, and parenting during the COVID-19 global pandemic. And then they go on to write that there was a groundbreaking article and it was replicated. The current paper extends pausing to plug in a tablet, this work, pausing to wipe a bottom, to parents, pausing to get somebody a snack, who are attempting to, pausing to set up a Google Classroom. And so you understand this is our, if we could count the number of interruptions we have, how are we getting any work done, anybody? And so you're unlikely to be as productive as you were in the office as a caregiver during COVID. And so how can we support that and say, we don't expect you to be productive, we expect you to get through this. And so one of the things to think about is for researchers, who can't write grants but are in those really difficult periods, can we provide bridge funding and promises that we're going to keep going? Can we provide waivers or clock adjustments in academia? Now, one thing to keep in mind is that this concern could make the disparity worse if it's not done well. And some of you know the tenure example, that when tenure clocks are adjusted, men actually benefit and women actually don't. And so the disparity widens. And so you have to really think about how are you going to apply it to the person, whether it be a man or a woman, who needs it the most, the primary caregiver in the household, or how do you work with households to really split the work? So can you create a contract with your partner to get that work done and be totally split? Because otherwise this could result in just a generation of women being delayed in promotion and leadership. Now, another plan I want to call out, my friend Mark Shapiro, who runs the Explore the Space podcast, for his idea on the COVID promotions program. And initially his idea was, why doesn't all this work for advocacy and media, we see a lot of doctors out there doing this work, why doesn't it count for promotions? And I actually thought, let's co-opt this and say, why aren't we accounting any and all activity we're doing during COVID, like including caring for our children and keeping things going in our communities? Why aren't we counting that? So perhaps you're doing advocacy. Maybe you've been redeployed and you're doing telehealth. Maybe you converted your practice to telehealth. Maybe your research has been totally halted like mine has. Maybe you're moving a course to virtual e-learning, or you're supporting well-being because one of your colleagues or maybe your husband is deployed, who knows? And so how can we really think about adjusting and adding this onto your CVs so your COVID time is accounted for? And so I'm just gonna give you an example of mine, which is I am not doing any clinical activity right now, partly because I have 2 children in the home, an age 5 and one who's just 8 weeks. And then my research has been halted, but I did have to report to the NIH that it was halted, and that took some work. I'm a collaborator on 2 ongoing studies that are sort of going on at a low level. And then I had to help with a team for prep for e-learning. All of that took some work to get executed. But this is just part of what I have been doing, because as many of you know, a lot of us need to speak up and use our voices. And so perhaps you're working with a team of people like I am with a nonprofit, or you're writing an op-ed, or you're just, sounding off on Twitter about, the need to wear masks. I would say all of that counts right now, and we should be counting for that so people understand what we're doing. Now, I wrote an asterisk for partial caregiving because I actually have been fortunate to start my nanny back up as I re-enter. And so, my COVID time would not be full-time caregiving. And I need to be honest about that so that people who are doing full-time caregiving during this period can get the proper adjustment. So this does require some truth to power to kind of make it so. I want to end with, is there a bright side? Because I don't want to be all doom and gloom. And so there was a paper, actually, could the COVID-19 lockdown solve one of the persistent barriers to gender equity in research? And it highlighted that travel is a problem. And so we actually do a lot of travel for leadership and, you know, visits, et cetera. And that travel is harder for women in medicine. And Kim Manning, who's a physician and Grady Doctor on Twitter, actually documented her virtual lectureship that she gave for Duke Children's. And it was a great example of like how you could actually, maybe this is a great equalizer. Another bright side is maybe we can spin this. And so is there a sense of urgency? We're here talking about gender equity. Australia has actually appointed their lead scientific, body to issue an Australian national report to ensure gender equity in STEM. And many of you know this commencement that's going on actually concurrent with this event. There's also a National Academy panel in the works right now. And so I would say the time is now, because if anything, COVID has unmasked this. Let's seize the moment to highlight the issues. And so a glass half full view might be, yes, we have a lack of women leaders, a gender pay gap, and potential bias and hostile environments and unequal home environments, I would argue, but now is the time to have those discussions. And so I know that there are a lot of solutions out there. These are just ones that I thought of, so I welcome your thoughts. And I wanna thank the Women in Medicine Summit team, as well as the groups on Facebook that have helped me prepare for this talk. And I look forward to your ideas as well.
Thanks so much, Dr. Arora. I mean, that was a tremendous amount of information, obviously giving the highlights, and hopefully we'll have some time during the panel discussion to deep dive into some of those aspects as well. Our next faculty speaker tonight is another incredibly accomplished individual. I have the privilege of introducing Dr. Niva Lubin Johnson, who is an internal medicine physician with over 3 decades of outstanding clinical experience, and who has held several distinguished leadership positions on the national level, including the first ever woman to serve as the president, speaker, and chair of the Board of Trustees for the National Medical Association, and chair of the Women's Physicians Section Governing Council for 2019-2020 for the American Medical Association. Her advocacy work of quality healthcare for all has led to numerous awards, including the Illinois Committee of Concerned Blacks in Higher Education Trustee Award, the Midwest Community Council Nancy B. Jefferson Community Service Award, the Dollars and Cents Magazine Best and Brightest Women in Medicine Award, the Kizzy Award, which is from the Black Women's Hall of Fame Foundation, the Student National Medical Association Award for Leadership and Service, and the Top Ladies of Distinction Orchid Award for Outstanding Women in Medicine. Dr. Johnson is also a former chair of the Board of Trustees of Chicago State University. This is notable because Chicago State graduates the most African Americans in Illinois that attend medical school. She's a founding advisory board member of Time's Up Healthcare, and with this pandemic and this disproportionate numbers of African Americans affected, Dr. Lubin Johnson is a member of the Illinois Department of Public Health COVID Equity Team. This team will also host the inaugural meeting of the Illinois Lieutenant Governor's Health Justice Work Group, of which she is a member. As those who are answering the poll, but it gives me a great honor and privilege to introduce Dr. Lubin Johnson to all of you. And she'll be speaking tonight on the topic of intersectionality as a lens into the COVID-19 pandemic. Dr. Johnson, thank you so much for joining us.
Thank you so much, Tom, for the introduction, and good afternoon to everyone who is participating today. As you heard, I will talk about intersectionality. Can I have my first slide? Who's advancing for me?
Perfect. And then Dr. Johnson, just to note, it looks like answering the poll question, the question was, do you feel your institution has effectively implemented gender equity efforts now? It's about 90% response saying the answer is no, which is sobering to say the least. But I'll let you take it away, Dr. Johnson. Go ahead.
All right, thank you. And so if you go back one slide, please. Thank you. So, it says, let's not lose ground. And I want to say we need to gain some ground when it comes to this area for intersectionality for African Americans and women, be they in medicine or not. Next slide. So as you all know, African Americans are 13% of the population. We're 5% of physicians. We are 2% of the women physicians in this country. Next So the reason for this number began after the Flexner report was published in 1910. The Flexner report deemed several African-American medical schools inferior. That's debatable, very debatable, and were subsequently closed. And only Meharry and Howard remained after that. The two next medical schools to open were, of course, Morehouse School of Medicine in Atlanta and Charles Drew University, which is affiliated with UCLA in California. There is going to be another predominantly African-American medical school opened in the next few years, affiliated with Morgan State University in Baltimore, Maryland. Next. So discrimination that's occurred before, since, has created what's called the slave health deficit. This contributed to disparities, or contributed to disparities in healthcare, lack of culturally competent health professionals, and of course, poor access to care. Of course, the creation of the Affordable Care Act has helped with that poor access, but we've seen how that has been assaulted in the past 4 years. And of course, with lack of culturally competent health professions, we also now know the need for training in that area, in particular, implicit bias training. Next. So the pandemic, of course, exposed, these inequities and so much more. Lack of testing. The testing that's going on now here in Chicago is like night and day from March until now. In March, I was doing a locums assignment at a federally qualified health center here in Chicago. I tested a patient who turned out to be positive. Of course, we had to go through screening and all of that. Her was easy because she came in, she was coming in, she was ill. On her way to the office, she found out she had been exposed to someone who was COVID positive a few days earlier at a party. But I did her test. It took 13 days for us to get the results. Okay, now I can go, there are 2 testing sites, one a mile and one about 1.5 miles from my house, which anybody who drives up will get tested. And so this has probably contributed to some of these awful numbers that we have seen, this lack of testing in the beginning phases of this pandemic for African Americans. And of course, part of this is lack of culturally competent, unbiased providers. We've heard time and time again how, African Americans and Latinas have gone to the emergency room, had florid symptoms, been turned away. There's a story of a Black man in Detroit. He was turned away 3 times, and by the time he got admitted, he died. Next. So, and of course, the increased rates of chronic illness has contributed to these rates also. Increased rates of obesity, of diabetes, of hypertension. We know how African Americans are outnumbered. The rates of occurrence occur so much more than whites, and this has contributed to this high rate of illness also. And as we go down this equity road and addressing these issues related to COVID, these other issues are going to have to be addressed, or else we're going to end up in the same spot with the next pandemic or health crisis. So, as you all have probably heard, be you from Chicago or not, probably around the 1st of April, mid-April, our mayor had a press conference where they announced the terrible numbers related to African Americans and the incidence of COVID. We're 30% of the population here. We're about 30-30-10. 30% African American, 30% Latina, 30% white, 10% others. And so, but at that point, we were 70% of the cases. Now we're down to about 60% because the incidence in Latinas has gone up, but I think a lot of that is because originally Latinas probably were not placed in the right category initially. I think probably they were, the data was entered as them being white or nothing, but now with some balancing, and there's some increased incidence now, African Americans are 60%. You see We are 20% of the death rate nationwide, despite being 13% of the population. And you see the incidence, you know, is twice as much in other groups right now. Next. So you've heard other urban areas, similar statistics, Milwaukee, Detroit, Atlanta. In St. Louis, the first 6 weeks, all deaths were of African Americans. Okay, all. I mean, just phenomenal numbers. Next. So what else contributes to this? Social determinants of health. And, you know, previous speaker, great presentation, alluded to some of this in her presentation. You know, and especially the jobs part she alluded to, that, you know, almost 80% of healthcare is provided by women, be, you know, physicians, nurses, cleaning the hospital, respiratory therapists, x-ray technicians, etc. So we're more on the front line. And so, you know, that has something to do with, and of course, African Americans have jobs that don't allow them to work from home. Only about 20% of us have jobs that allow us to work from home. Housing, you know, living in congested situations, you know, 5 people in a 2-bedroom apartment can't be socially distant. And so that creates an issue right there. If somebody gets positive, what do you do? And of course, transportation, more of us are on public transportation. Now, you know, we see what has happened in New York, and New York has shut down their system from, I think it's 2 a.m. to 5 a.m. for deep cleaning every night. And, you know, I think that needs to be done nationwide. If they haven't figured out some way to do deep cleaning of buses or trains during the day to prevent transmission. Next. So other inequities were exposed. You know, I talked about testing, inadequate treatment. We've had in Chicago, we had a hospital, Trinity Hospital had to stop labor and delivery. So they had enough beds for COVID. And as you saw in the first slide, I am actually emeritus status at Advocate Trinity Hospital now. And so you've taken away a necessary service, all right, to add a service. And for those who are not familiar with Chicago, I will share that 2 miles almost due north of Trinity is Jackson Park, which also closed their labor and delivery services last fall. The next hospital just east of there, South Shore, doesn't have labor and delivery. And if you go to the west and a little north of where Advocate Trinity is, there's St. Bernard's, which does. And then the next hospital north is the other hospital I'm on staff at, Mercy. I will share that there was a proposal for 4 of the hospitals that I just mentioned to come together to merge and form one institution. And those 4 hospitals were looking for funds from the state to start along this way. Unfortunately, COVID came along. Our legislature just completed session last week. That legislation did not happen. And I have been told that Mercy Hospital, the one to the north, this was the plan B for them. Plan A was they were already going to file a certificate of need with the state to close. And they do labor and delivery. So you've got 5 Southside hospitals, 2 without labor and delivery, 1 getting ready to close. Dire situation in that area. And we already know about the numbers with maternal mortality for African American women. Next slide. So, you know, Vinny talked about us being head of households, single head of households. You know, so we're working because we can't be at home. We have now become the educator because the schools are closed, the babysitter because daycare is closed, caregiver if you're in the sandwich generation and you gotta provide care for parents or grandparents. So, and then on top of this, if you're in healthcare, lack of PPE, and then ill-fitting PPE. So, you know, just a lot to have handle at this time. Next slide. So what other issues when we talk about healthcare and medicine? You know, our pre-med students, our med students not being able to get the reference letters for medical school and residency. Our residents not getting the cases they need for program completion. I just read where step 2 of USMLE has been put off for a year. So, you know, the ramifications of this are serious. And I think that on top of the things that Vinny talked about in terms of research and publishing, you know, it's really compounding the things that how this pandemic can be affecting women. Next slide. So, you know, she talked about research interrupted, delayed because of carrying all these roles, not being able to publish. She just alluded to that with the COVID publications, how this is going to be a problem with promotions and furloughs and salary cuts going on. We saw a post from an AMA member earlier this month who got fired from her job because she didn't want to accept patient that she thought was going to her unit. She's geriatric psychiatrist, I believe. And she was afraid of exposing, you know, an issue of COVID with that, and they fired her. You know, people are being furloughed, you know, salary cuts also are going on. And, you know, for us, for physicians. And so it's really, really a problem. Next slide. So what are solutions, okay? Solutions in terms of creating equity. Last year, ACGME created its first diversity and inclusion department and hired that officer, who I'm happy to say is a good friend of mine, William McDade. And then this year, he hired another friend of mine as his vice president, Bonnie Simpson Mason. And I think, you know, they make a great team. You know, Bill has been dedicated and been a tremendous academician his whole career. He's always had an interest and a purpose and a goal of increasing diversity, no matter where he worked. Dr. Mason is an orthopedic surgeon by training who had to leave that profession because she developed rheumatoid arthritis. And so it was no longer good for her to carry on in that profession, but she reinvented herself. And one of the things she did besides creating a business to help physicians with, you know, consulting, being a consultant and helping physicians with contracting, et cetera, she also created a not-for-profit to help increase the numbers of women and those of color going into orthopedic surgery. That program has now expanded to help those going into dermatology and also radiology. Next slide. And of course, last year also, the AMA established the Center for Health Equity. This came about because in 2008, AMA, along with NMA, started a program that was hopefully to help create a more diverse population. It came about after AMA apologized to NMA for excluding African-American physicians from AMA, and that they were elected to sunset that program in 2016 or 17. Fortunately, how policy gets made in our House of Delegates, and a resolution came to look at the need for something related to equity. A friend and a trustee of AMA, Willarda Edwards, chaired that committee, and out of it was the creation of the Center for Health Equity, of which Aletha Maybank is that Chief Health Equity Officer. And as a benefit in this time of COVID, Aletha was formerly an Assistant Commissioner of Health for New York City. So the AMA really lucked out on getting her expertise last year. Next slide. I am also a member of Times Up Healthcare, and Vinny talked about that a little earlier. Esther Chu, that powerhouse and champion for women, is the founder, and Lauren Powell is now our executive director. Lauren was with the Virginia Department of Public Health. I believe she was the assistant commissioner there before she came for diversity, before she came to Times Health. Next slide, and I think it's my last one. Not next to last. So now in the future, STEM programs are needed, and there are some that foster interest in medicine for children and teens. But also we need implicit bias testing and training, and we need some repercussions for when issues arise from people being treated with bias. The study I like to talk about the most in this area is from the Ohio State University, as they refer to it, and Quinn Capers, and he is a cardiologist there, and an academician also. And in, I believe it was 2012, they decided that everyone who sat on the medical school admissions committee would do implicit bias testing and then some training. And then the following year, they admitted the most diverse class in the history of that medical school. And so, I think everyone needs to partake in it, especially those of us in healthcare, to make sure we get it right, to make sure we don't misdiagnose, to make sure we, don't underdiagnose, to make sure we don't overdiagnose or overmedicate. But we all need it so that we understand the patient's full perspective, their social determinants of health, why they're there, and not judge also. Next slide. And I think this is the last one. And so, as chair of AMA Women's Physicians section, we really do take seriously the concerns of women physicians. We just did a new strategic plan this year, and policy priorities do include issues related to one that Vinny talked about earlier, the pay gap. Why is it that no matter what specialty, what setting, women are paid on average 20% less than men are? And so we're going to be looking at what policy can we create that's going to help with that being alleviated, but also programming where we have men talk about that, he for she, men who are supportive of women. And actually, if the House of Delegates in the annual meeting would have occurred next Saturday evening, June the 6th, that was our intent. That was our business meeting program, was he for she. If we do meet at our interim meeting in San Diego in November, the plan will be to have someone talk about burnout, because we know that is a serious issue for physicians, women physicians in particular. Suicide is now the number one for physicians. We're the number one category, and women physicians outnumber men 2-to-1. So that concludes my talk this afternoon. I hope you all enjoyed it. I enjoyed giving it. Thank you.
Thanks so much, Dr. Johnson. That was a phenomenal talk. And in the time that we have left, realizing that both of these topics are in-depth topics that we could even develop thesis subjects on for PhDs, we'll try to hit a couple of high-level questions as well. First, there's a poll that's going on right now. So as we're discussing this, I encourage the audience members also to take a look at that poll. First question is to Dr. Arora. It's going to be a two-part question from the audience. The first thing is, in your opinion, what's the best way to approach the equity and equal opportunities at work?
That's a great question. And I would say the key is knowing your allies and the people that have your back. So I always say you have to have a good understanding intellectually and emotionally of where you're working. Ideally, that would be a sponsor or a boss. I will say through my work, not just with Time's Up Healthcare, but with the National Academies and others, power structures are real, and they're especially real in healthcare, and they're especially real for women and those who are at the intersection, as Niva mentioned. And so I wish I could say one canned answer, which is go to your boss. But obviously some people have more support there than others. So one question for you is how good is your organization advanced is your organization or employer thinking about equity and inclusion issues? Is there, if you're at a university, there's probably a dean or director overseeing this who could be somebody that you go to. That's sort of an ombudsman, if you will. If there is, if you happen to be a woman in predominantly, I hear from a lot of women who are in predominantly male fields, and they're like, what can I do? Can you go to a senior woman in a different field and say, help me navigate this situation? And so at the end of the day, in order to really set things straight for yourself, you will definitely, the path will go through the people who are the decision makers that influence you, but can you accumulate some allies in powerful positions who can help you along the way is the key.
Connecting with allies. No, that's a great answer. And just noting that the poll question was, are you concerned that gender inequities in healthcare will widen due to this pandemic? And 95% of our attendees tonight are significantly concerned about that. Not surprisingly, hence the reason why we're having this conversation tonight as well. Dr. Johnson, the next question is to you. This is from Dr. Susan Lopez, who says that reaching out to communities of color to talk about how to protect and care for themselves and their families, that is culturally competent and takes into account social determinants of health, is traditionally difficult as it is, and it's even more difficult now with physical distancing. What ways do you think might be the most effective in terms of reaching out to the communities? Because we know the status quo is not acceptable.
So, fortunately, I've been able to take part in a task force that you mentioned to help with some messaging related to that. But, for her personally, I would say with patients, one-on-one, talk to them whenever you encounter them about what they're doing. Where are they going? Who are they being around? How often is it occurring, et cetera. But then I would encourage messaging to come from if you have input to your local government, if you have input at your hospital or health system, or if you're, part of a system, to make sure that some kind of messaging is going out, that says socially distance, you should wear a mask. Churches is another area with this occurs. I attend a church, and before we went into shelter in place, when this pandemic started, member of my church was someone high up in public health, and he spoke to us, weekly until, and I think even after the shelter in place started for the first couple of services afterwards. And we still are shelter in place, and we're over 5,000. So we're going to be in shelter in place a long time. So I think those are the ways that you go about it. And I just want to say a couple of things about being in Chicago and Illinois. I don't know if you all saw the AmericanIndependent.com story, but Illinois is the only state in the country that has achieved the 5 CDC guidelines that were distributed several weeks ago, which unfortunately got thrown out the window by this administration. But we have achieved that. And so I am very confident in what our governor and our mayor is doing.
Oh, thank you for that, Dr. Johnson. And it's interesting, one of the names that you mentioned during your talk, Dr. Bonnie Mason-Simpson, is actually one of the keynotes at this year's Women in Medicine Summit. So appreciate you highlighting her work as well. Dr. Arora, next question is to you. You talked about, it's difficult in general to publish, but there are some amazing work coming down. How would you advise reflecting this COVID time on like your academic CV or annual evaluations? Is it that grid that you showed during your talk? What would be some best tips for that?
That's a great question. A few people have asked me and said, "Oh, my institute." I serve on my promotions committee, so I should disclose that to anyone who's watching from University of Chicago. I will say, if you build it, they will come. So I would not wait for this stone tablet to get handed to you from the promotions chair to say, "Here's how you adjust for your COVID time, and be sure to use your asterisks, and it's okay." I think that it's behooves us to take a charge and say, "Hey, this was a great seminar and an idea, and I'm gonna throw this out there." And actually, one thing that happened, which I felt pretty bad about, was this just reflects what we were thinking with COVID, which was we were just dealing with the crisis at hand, like day to day, which was I was hearing from mentees. I run mentoring programs, students and residents. My conference got canceled. What am I going to do? And I'm like, you're going to put it on your CV with an asterisk, and you're going to say COVID conference canceled, or institutional travel ban, unable to go. And then actually I saw a website that somebody posted on their blog and said, here are some best practices. I'm like, great, let's cite this website. We'll put it on our website. We should not shy away and say, we need somebody to hand this to us. We should create our own, spread it amongst ourselves. And so several of us are working with Mark Shapiro to actually think about this. Since he started this idea of a COVID promotions program, we are working with him to figure out how to formalize a template that we will release, and certainly with Shika's help through Women in Medicine Summit as well. And I will say that my experience has been very similar to social media. And so some of you know Dr. Avi Glasser from OHSU, been a pioneer in really documenting social media contributions on your CV. Again, I'm on my promotions committee, and somebody was like, "Hey, Vinny, did you see this thing?" And I'm like, "Yeah, I did." And so they're like, "We should use this." And I'm like, "Yes, we should." And so that should be our thought there, which is how can we lead the way and make it better for others who are coming behind us, as opposed to waiting. And so I would start somewhere. So start with the grid that I have and reference this talk. Maybe you'll improve upon it and put it in the public domain, and I'll reference yours.
No, that's phenomenal. In the time that we have left on the screen, most of you are probably seeing an image that Lauren Green has put together, highlighting some of the comments. She's affectionately known as Dancing with Markers on social media, and so we'll obviously share this widely as well. It's amazing that the hour has gone by, but I'll turn it over for closing thoughts. Dr. Johnson, closing thoughts from you in terms of taking into account the pandemic has been devastating on so many different aspects. The intersectionality issues obviously highlights the disparities that we already have. From your thoughts in terms of how the path forward to correcting all these ills. Dr. Johnson?
I'm sorry. I thought you were asking.
No, sorry about that. Yeah, I was at, do you have any closing thoughts for
Oh, thank you. So yeah, I just want to once again, thank you. Thanks for the opportunity to, present this afternoon. I really appreciate it. I think that, I hope you all go out and think about how we can all do better with equity, both in healthcare and also otherwise. We had a terrible incident occur in Minneapolis, and I think there's some implicit bias training, testing, and a whole lot more needed there. And I think we have to take that into account also as part of this march towards equity, be it in health, economics, justice, etc. So once again, thanks.
Thanks, Dr. Johnson. And Dr. Arora, any final thoughts for our audience tonight?
Yeah, thank you. First, thanks for having me, and just piggybacking on Dr. Lubin Johnson's comments, like we can all be allies. I'm heartbroken by what's going on in Minneapolis for so many reasons, and and very worried. And so I think we all have to stand up for each other, no matter what the circumstance is, because of the just inequities that have been unmasked, and whatever we see, we need to stamp them out. And then the last thing that I'll say is to you, Tom, Dr. Varghese, I would say we need to not forget our men. And so how are we gonna partner with you as a wonderful he for she and all the others out there to say that we're gonna all do this together, because it's not gonna be just women, not just people of color, not just you know, trainees or people on the margins. It's gonna be everybody in this, all in it together.
No, thank you. It's a privilege for me to be in this audience tonight. I mean, I think one of the things that I've learned over the years is, you know, what my mom affectionately told me is always surround yourself with people that are way more intelligent than you, and you'll do good in life. And so I thank you all for that. With that, I'm going to turn it back over to Dr. Shikha Jain for some closing thoughts. But thank you all for participating tonight. And Dr. Jain, I'll let you take it away.
Thanks so much. This was a absolutely phenomenal webinar. Thank you to Dr. Arora and Dr. Johnson for being here and sharing your wisdom. Thank you to Dr. Varghese for leading this very challenging but very important conversation. So I want to remind everyone, you will be getting a recording of the video. You will also be getting the image that Dancing with Markers Lauren Green created that you saw at the very end. You should also be, if you haven't received it yet, you should be getting a discount code to register for this year's Women in Medicine Summit. And I want to encourage you to register. It's a completely virtual summit this year. It is CME. And we also have a he for she track, which Dr. Varghese is one of our leads on. So please register for the summit. We're going to have amazing opportunities. And even though we can't get together in person, hopefully you'll feel the warm fuzzies as if we're all together, because we'll be networking and talking, and we'll have some really unique and creative ways to get together and to chat and to hopefully create a revolution and hopefully not lose ground with this COVID-19 and keep working towards these equity efforts. So thank you so much, everyone. We'll see you at next month's webinar. You'll have details on that coming out soon. Check out social media, subscribe to the Women in Medicine Summit newsletter, and everyone stay safe, stay healthy, and we'll see you soon. Bye.
Bye.